Good morning, everyone. For those of you on the West Coast, it's an early morning, and thank you for joining us. My name is Karen Taylor-Hughes. I'm the chair of the Pan-Canadian Change Management Network and work at Canada Health Infoway as a benefits realization leader in change management. Thank you for joining us this morning for our workshop. I'm going to get a few housekeeping items out of the way, starting with the notice that this webinar is being recorded and may be posted on Infoway's website. All participant lines are muted throughout, so you will need to use the Q&A feature if you do not wish to use it, if you wish to ask a question. A disclaimer that I'll give you a few minutes to read on your own is available to look at on the screen. Again, joining us today, we're happy to have 4 presenters: Anne Baldwin, Melissa Chang, Diana Benjamin, and Chad Lever joining us today. Again, our objectives for this webinar are 3 elements from the National Change Management Framework, focusing on workflow analysis and integration, training and education, and monitoring and evaluation. We're going to hear stories from an Infoway change and evaluation specialist, CGTA change leads, and an Infoway benefits evaluation leader about how these change management elements have been leveraged for success. To ask questions, please use the Q&A panel at the top of the WebEx screen by clicking on the drop-down arrow, selecting Q&A, and sending your questions to all panelists. The question and answer period will begin after all speakers have finished their presentations. Unfortunately, we may not be able to answer all questions, but we'll try and get to them as much as we can. Canada Health Infoway is a independent not-for-profit corporation that we began in 2001, and our mission has been to foster and accelerate the development and adoption of electronic health information systems. And that's part of our mission, and all the things that we do support that, including our Pan-Canadian Change Management Network and the work products that we complete. The Pan-Canadian Change Management Network, supported by Canada Health Infoway's clinical adoption team, is a grassroots collaborative of change leader enthusiasts from across the country sharing best practices and ideas since November 2009. The network facilitates a national community of practice for change management leaders involved in the implementation of electronic health solutions, providing an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns within the digital health space across the provinces and territories. The Pan-Canadian Change Management Network has developed an integrated framework for describing change management activities within the context of digital health solutions projects that consist of these 6 change management elements. More detailed information for each of these elements can easily be found within our online PCMN community via Infoway's corporate website. And you'll hear more about this when we cover resources at the end. Now to our future presentation. I'm going to hand it over to Anne Baldwin.
Thanks, Karen. So the first section that I'll be speaking to is workflow analysis and integration. So it's a method of understanding work processes and looking for opportunities for improvement. By conducting workflow analysis, it allows the new digital health processes to be embedded into the culture and hopefully ultimately sustained over time as a new way of doing business. So why do we do workflow analysis? As I mentioned, it is a way to stimulate critical analysis of what we're currently doing in the work environment. It provides an opportunity to determine if these processes can be improved or if they can be streamlined for efficiencies as we move towards the new digital technology. And it can either shape the new system if it's in a design phase where you have that opportunity, or if the system has already been determined, it allows the user to take full advantage of the capabilities of these new systems. I always like this cartoon because basically it's saying, now let's pick the innovative idea with the greatest potential to keep things exactly as they are. So often when we do workflow analysis and integration, clinicians see it as an opportunity to look at ways of coming up with innovative ideas, but most often what ends up happening is that they would like the exact same process carried over into the new solution. It isn't that they actually particularly like the current one that they're using, but it's just what they know. It might be time consuming, it might be very inefficient, they might have a lot of workarounds, but it's what they're familiar with. So that's what sort of their thinking would need to carry on into the future. So it really actually becomes a three-step process. The first one is looking at what is currently being done in the workflow, allowing a time to look at opportunities. So that is really the second one, where there's a what would it look like, what could we do, and then the future state. If we don't do that piece in the middle where you're looking at the opportunities, what ends up happening is basically you automate poor process or current process. It may not even be poor, but it's certainly not innovative and probably won't meet the needs of the future. Whereas workflow analysis truly is an opportunity to allow clinicians to look at what if, and what would it look like if we had this chance to make it what we wanted it to be. So how do we do it? Obviously, the first way, and one of the most critical ones, is to engage the users and the clinicians who will be impacted by the digital solution. As I mentioned, step one is looking at the current workflow. And there's two key pieces within that. One is to ask them, tell me how you do something, either a task or a function, and then write that down in a logical step manner. But also equally important is actually to watch them and observe them, because it's always very interesting to see what they will tell you they do, and then when you actually watch what they do, most times what I find doing workflow analysis is that people forget many of the steps that they do that may not actually be their work process, but they have interdependencies with other clinicians or other areas within the system, and equally as important to appreciate that. And they often underestimate what they do when they verbally tell you what the current workflow is versus watching them actually do the task or the function. And then, of course, validating back to the users so that there can be a common agreement that this is the core workflow that we do every time. As I mentioned, the third step is trying to create that future state. What would that look like if we had that opportunity? Sometimes we do have that opportunity to create what that will look like, and then we can identify the gap between what is current and what is the future state. And then, of course, the key question is, what would it take to get us there? So who would complete the workflow analysis? Ideally it would be a dedicated project resource that would work on the workflow analysis, either an analyst themselves or a change leader or a clinician champion. Realistically, sometimes a dedicated resource independent to somebody who has other operational responsibilities isn't feasible, but it is ideal so that it's not being done on the side of someone's desk. But if it can't be done, it can be done or can be included in someone's current role as well. And as mentioned, it's really key to look at all of the impact or all of the workflows to make sure that you're able to identify the ones that are impacted, not just the main one that is the clinician or the workflow that is being looked at the moment. One project that to me, exemplifies that in terms of looking at the workflow involves electronic ordering and requisitions of diagnostic imaging tests from a specialist office directly into the imaging department's digital solution. So in the paper version, the specialist orders the test and the support staff completes the requisition. In the electronic version, the specialist places the order, which is standard and expected. However, the way the electronic solution was designed, the specialist, he or she must enter all of the requisition data to complete the ordering process electronically. So in that case, the specialist has to find the height, the weight, the recent lab tests, the allergies, all of the other components before the order can actually be processed through as a completed order. So clearly, the electronic system does not match the current workflow, as there's a disconnect between what is currently being done by the specialist and what is currently being done by the support staff. And that was basically because when they were looking at the process for the requisitions, they only looked at the support staff identified the current workflow of the support staff, but didn't recognize that if they combined the two together, it would impact the specialist. So currently, this situation is being reviewed to determine what is the most efficient process and what is legally allowed in terms of delegation of orders, because basically the digital solution, the way that it works now, isn't efficient because that's not what's currently happening. And in this example, the groups, in terms of time and efficiency, it isn't the most efficient to have the specialist trying to find the other data components to complete the order as it would be to have a support staff completing those pieces. So how do we do this? Well, definitely, as I mentioned, there's always that struggle between the technical and the clinical requirements when implementing a new solution. So ideally what should happen would be to look at those new work processes, incorporating both the best practice from the clinical piece as well as the technical or business requirements. And as I've mentioned, often the digital solution is already chosen or in existence, so then basically having to try to work within that to come up with a solution that is agreeable. If you do know the future state, so that you're not coming up with a green field, but it has already been determined and a product has either been chosen or it's already in existence, it still is beneficial to do the workflow analysis. And then in this case, what I determined is more of a fit analysis can be completed, which allows the users to identify how well their ideal workflow fits with the technical requirements. Sometimes there is opportunities then for some upgrades or some minor customizations or modifications. And in particular, it identifies any key clinical requirements that are needed, especially related to safety. Sometimes the solution, especially I've seen with pediatric models or modules, need different functions if you're working in a pediatric environment than if you're working in an adult environment, and that specificity isn't there when it's in a general solution, but needs to be modified for patient safety for the pediatric population. So in terms of after that it's been done, it's still actually really important to look at the workflow and to see are people actually working on completing the workflow as they thought they would? Are they using the system the way that it was intended? Does it meet their workflow requirements with minimal disruption? And already are workarounds being utilized? Sometimes workarounds are required and they're just sort of natural human behavior and are beneficial. But sometimes it might be that the users or the clinicians don't appreciate what the new system can do, and they're building in workarounds because that's what they've been accustomed to in the past. And we had one group in the West that talked about it unleashing the power as a solution. We often call it optimizing, but I kind of like the unleashing of the power, which is true. Sometimes people just don't really appreciate what the solution can do for them because, again, they've sort of just transferred over what they do in the current environment to the new setting. So just to summarize then, the key components of the workflow analysis and integration, really realistic and clear expectations for the end users. I can't stress that enough. If the end future state is already determined in terms of a solution has already been purchased, be very clear about that so that they understand the parameters they work within. If it is a green field where they're able to help shape that and design that, that's great as well, but as long as the expectations are clear. Also realistic and clear expectations for the IT staff and the vendors so that they can appreciate that there are clinical requirements that are essential, that are critical, that would necessarily require some updates or customization, and this is the environment they're working within. Absolutely take it as an opportunity for innovation to not do what we've always done, but to think what would you actually really like to be doing that would be best for the patients and the clinicians and the system as a whole. If nothing else, workflow analysis truly is an opportunity to foster engagement. As I mentioned, sometimes people don't realize how they are interdependent on other parts of the system, and that provides us an excellent opportunity. And ideally, it's not a one-time event. It can happen while you're in the design phase or in the building implementation phase, but once they go live and afterwards, it's always great to do rechecks on the workflow analysis because, as Beck practices emerge, as patterns form over time. We want to make sure that the process continues to be the most efficient and is constantly improving rather than is using solutions and processes that are outdated. I will pass it over then.
Now we're going to have Melissa and Diana speak about training and education. Our framework section, this is about the act of imparting knowledge and specific skills among key stakeholders to successfully use new technology and promote adoption.
Good morning, everyone. Thanks for joining us today. So as Karen said, my name is Melissa Chang, and I'm the Stakeholder Engagement and Communications Lead for the program. I'm joined by Diana Benjamin, who's our Adoption and Training Lead. For those of you who haven't heard of Connecting GTA, we are one of 3 regional integration hubs in Ontario. We're working with both eHealth Ontario and Infoway on this program. We are the first, and in terms of population, we're covering about 50% of Ontario's population, so the first and the largest of the hubs. Based on the feedback we received from last month, we're not going to provide much of an overview on the program, but we did provide a video in advance just to set some context around the scope, scale of our program. If you haven't had a chance to see that, it is available on our website that's at the end of our deck here. And of course, we're happy to share any references or tools that you might see that you're interested in post this call. So I'm just going to click to the next slide. I'm not going to provide an overview of the program, but I did want to give a sense of where we are in terms of our stages. So we are currently in an early adopter phase, and we're actually just about completion with our limited production release. So what you'll see on this slide are just the numbers, a few numbers that we thought would be of help just to set context. So we're working with about 16 contributing organizations that are actually helping us capture about 75 million messages. In the end, we will be reaching out to close to 40 participating organizations and 20,000 clinicians who will have access to our system. Currently in our LPR, if you just take a quick look at the bottom of the screen, we have about 75 clinicians using the system currently and giving us feedback. We are tracking just access for this current phase, and we're roughly at about 30% of registered users using the system each week. That's higher than what our end target is eventually going to be, which we're aiming for about 20% in the end. But these are clinicians who have been engaged in the process throughout, and they're keenly interested in helping to shape the solution. So that's where our numbers stand as of right now. Just going to move on. In terms of our adoption and training approach, we had the opportunity to provide an overview during the last call. We have worked very closely and used the CHI CM framework, as well as are very closely aligned with ProSci and the ADCAR model. What you'll see on this slide is our integrated approach and the phases that we're taking our stakeholders through as we consider our change management needs. We covered off the first 2 in our last webinar, and today, as Karen suggested, we are focused on the educating and exchange phase, so education and training, and that's what we'll focus on, primarily from the clinical stakeholder group. That's what the materials and the process we'll be speaking to are covering. So in terms of the first point that we wanted to highlight is that from our perspective, when we're going through the education and training, we have a large target of 20,000 users. We have a very small team within which to reach out to that large group. For us, the key at the very beginning was that education is really for everyone when we're thinking about the campaign. We really wanted to make sure that we could reach a broad range of stakeholders and really focus our education efforts on that. But how do you actually do something like that when you have a very diverse group of stakeholders, a new initiative with so many unknowns? The first step we took was really identifying who of those users or of our users, who are they most influenced by? And we hear a lot about this in change management frameworks, but we focused on, who are these clinicians really going to be getting their information from, and who will they tend to be asked questions of? So what you'll see on this slide is first, there obviously are their colleagues for our clinicians who are involved in this program. The executive sponsors, so largely in our case, many CIOs or IT directors, and then also site project managers that we work with from each organization. So then on the other piece is, how do we actually manage getting out to all of these different stakeholder groups with a small team. I would highlight 2 points and ask you to consider this as you're thinking through your education plan. One key was that we focused on one vehicle per stakeholder group. And largely for this, we focused on providing bulletins that were no longer than 2 pages for each group. And these became regular channels that were short, quite quick to do, but were shared on a regular basis so that we were continually providing information. So I'd say we focused on one vehicle. We didn't open up and have newsletters and all sorts of things. We focused on one bulletin per stakeholder group. And then the other piece that was key for us is our distribution was based on milestones rather than a regular schedule around having something done weekly or on a monthly basis. We really focused on when are we going to have key decision-making points or key milestones that would be of interest for each stakeholder group, and then we started to share information starting with those. And how that really helped us was it was consistency in terms of the types of material and level of detail they were getting. But because we were focused on milestones, it really allowed us to make sure that when we were delivering content, it was actually answering the what's in it for me. And so over time, I think it was easy for our stakeholders to really incorporate reviewing that information as part of their regular day-to-day. And at the beginning, they didn't know who we were, but over time, as we started delivering more content that was valuable to them, rather than expecting, oh, that should be coming out this month or this week, whenever we did send something, they were paying attention to it. So I think that was a key benefit for us. Once we got through the education and making sure we had kind of ongoing support for this, we then did look at gathering input from our different specifically for our clinicians. And I've just pulled up on the slide is that the few key points that we wanted to highlight from what we heard. I don't think they're net new, but I'll quickly go through them here. They wanted us to make sure that we were guiding this program and delivering materials centrally, but that they could execute and have the flexibility to do locally. They wanted to make sure that in everything we did for education and training, clinicians were involved in every step of the way, from format to level of detail, that kind of thing. Customizable materials. So sites had to have the opportunity to be able to do it, tweak it for themselves, but still wanted to use templates and make sure that they were consistent with what we were saying and how the product was acting. And then, of course, keep it brief and relevant. So moving from there, we had talked a lot about streamlining the touch points, and that's exactly what we did for the clinical audience. How does something like this work for a clinical program? It's a long-term program. There was no system at the start. We really needed to educate on 2 levels. So one was the program and the product. And we channeled all of this. What you would have seen at the start of this slide was an information or a toolkit that covered everything to do with communications adoption and training. This became the source of truth and also a step-by-step guide to help develop different plans. And it was helpful for both site PMs and clinician champions. It really helped that as we went along the way, we were having materials developed that helped keep things fresh. And a bit of, I think, what we talked about is just kind of a bit of a keep them coming back for more strategy. We relied really starting at the top. We kind of titled this Decks to Demos. We didn't have a product at the beginning, so we were really dealing with a lot of presentations, written material. Over time, we were able to then create a video once we had an environment up and working, a video, and then we quickly moved on to demos. So over time, I think if any of you have had a chance to see it, the video, we did tie it actually, would be familiar with the Infoway's Knowing is Better campaign. So we very purposefully tied in. We didn't want to duplicate any materials because we did get good feedback from our clinicians that those videos helped to understand overall e-health landscape. But what we wanted to do was build on that knowledge, and so our campaign became Because We Need to Know. So we used that video, and then from there we were able to then move into live demos once an environment was available. I'm going to quickly move just to my last slide before I transition to Diana. But really focusing on clinicians as communicators. I'm sure, as many of you do, we were very conscious of focusing, very conscious of making the best use of our clinicians' time where possible. I don't know, I'm sure that many of you have had the same experience, but we often find ourselves trying to represent the needs of our clinicians and putting out their perspective and their input only to find that, once we get a clinician in the room and they're saying the exact same words as we are, they're getting a completely different reaction, or change is much faster from clinicians. So we knew that right from the start, and there's just a different level of credibility once you get clinicians speaking directly to, whether it's your vendor or a privacy and security expert, there's a different level of attention being paid. So we knew that from the start, and what you'll see here is we held a series of clinical solution sessions where clinician champions from every organization had the chance to participate in understanding what the base level product was, and then where we could go about changing it and what the impact it would have from a vendor, a privacy, a technical, an adoption and training perspective. So all of those pieces were in the room, and if you take a look at the slide, the product demo, we had the chance to pull up the demo on one side and then walk through questions and options on the other. You'll see that around the room we had scattered subject matter experts, so all of those different perspectives I just shared, and then throughout the majority were clinician champions. That really helped. I would say if there was anything that we would keep, if we had to keep one thing on this program, it would be these sessions. It helped to educate the clinicians along the way of what they could expect from the system and manage expectations. And then I would say, given what Anne was speaking to earlier, it really was a starting point for us in terms of understanding our workflow analysis, because we were able to discuss options around, if we change this, what would it do, how would this work from a clinical workflow, and how would it work from a privacy perspective. Everything was covered in the one room, so we had a very good dialogue. So it really was the start of some of our really great workflow analysis information. So that's a highlight. We could probably spend a whole session on that, but I will hand it over to Diana to move on to some of our training activities.
Good morning, everyone. So, pardon me, just following on what Melissa just said, during our clinician solution team sessions that we held with the clinicians, one thing that they did say emphatically to us was that we really don't want to be trained. They know clinical systems, they use them within their daily workflow. So what they saw that was being created was really to integrate within their existing workflow. So they were very clear with us that we don't want to be trained. What our clinician participants didn't really realize at the time, and they were primarily physicians, and they were primarily our clinician champions as well for their organizations, was that the solution that we were building was for a variety of different types of clinicians. And that, so some of these folks didn't all have knowledge of clinical information systems, so we needed to keep that in mind. What we discovered through the change readiness assessments that we've shared with folks and through the training needs analysis was that the site project managers that Melissa referenced earlier and site trainers who we also engaged throughout our process was that they had established processes and established mechanisms for training their own users. So although clinicians told us that they didn't want to be trained, what their resources within their own organizations told us was they have dedicated training resources and training processes for those folks. And that connecting GTA would actually fit in to their existing training plans and their processes. They told us how they wanted to be trained, and through the, they told us how they wanted to train and the materials that they would need for training. So the first slide to the left, on the slide that you're seeing here, is just some analysis on what the site trainers and the site project managers told us in terms of the type of materials that they needed. So most organizations are now in an e-learning environment. They wanted online tutorial type of information that they could then customize for their own purposes. The other thing that they told us through their site training plans, and there's a sample of it on the right there of the screen, is that they had a method for training the 1,000 or 5,000 or 12,000 users that were going to be rolled on to Connecting GTA. And so through that, they actually told us what they would need and how they were going to deliver that training. And they also told us how much time they would need to customize materials once we provided it to them. So the three charts that you're looking, or the three examples that you're looking at here, is what the sites have told us they needed in terms of what they needed to deliver, how they were going to deliver it, and how much time they needed to customize that information. One of the pieces of information that we also asked sites was whether or not clinicians needed to be trained prior to accessing the clinical information systems within their organizations. And to date, only one organization, a handful of organizations told us that they do require training before folks get access, and really it's only mandatory for one organization necessary. So then we have an approach in terms of teasers. So we talk a little bit about how do we continue to maintain awareness of the program and help folks educate internally as we're developing. So I know that we were pretty ambitious in terms of our planning and when we would roll out and how it would roll out. But what we realized is that as the program changed and as we encountered delays, we actually needed to adapt our materials and our approach and be flexible in how we develop things. So Melissa spoke earlier about a video, so we did provide the video to sites. We also created a poster that actually talked a little bit, told the story of what Connecting GTA was and who it was trying to target. Then we looked at how can we support the sites in helping to position their champion as the person who had the information about the solution. And so we focused on some site-specific campaign materials. We've developed a template, a presentation template that the organizations can use for their adoption roadshows. So this is a key component for each of the organizations, that they host an adoption roadshow prior to when they're rolling out and going live, that the clinician champion will host an event to talk about Connecting GTA, whether it's at one of their medical advisory committee meetings or one of their rounds, a departmental meeting, senior management, board meeting. We provided a template of a relatively large presentation that they can scale and adapt to tell the story of Connecting GTA for their own organization. And now we're at the point at which we're sharing, collecting clinical stories and sharing that information back across the organizations broadly, but also looking at how they can use those clinical stories as they're using the solution now within their own organization. So we've looked at what they've told us, and now we're sharing it back with them as to how they can use that information. So we've gone from teasers to training. Training has been probably the one area where we've had to be very, very flexible and adapt to the needs of the clinicians. So throughout the LPR itself, we have done direct to clinicians. We trained the 75 users directly. We used a demo of the solution itself in our development environment so they could actually see it. And we held it through webinars with the clinicians. They were roughly, half-hour presentations about how the solution worked. And these were mandatory sessions. So mandatory training was required primarily because of the privacy component related to Connecting GTA. We needed to deliver the messages directly to these folks because at the organizations, they were not ready to share the information with their clinicians. So for us to share the information, we made training mandatory. We also we're trying to understand clinical workflow. So we have an online feedback form built within the portal itself, where we've been gathering information from the clinicians to find out how they're using Connecting GTA so that within their daily workflow, so that we can share that information with them. And as we move on to expanded clinical use and full go live, we are implementing a trainer-trainer model so that we'll be working with site trainers so that they can then deliver training directly to their end users. And of course, full go live will be continuing that trainer-trainer model so that they can roll out to their audiences as needed, and we'll be providing materials as necessary. So throughout, we've had a variety of ways that we've done monitoring and evaluation on an ongoing basis within our program. And we've actually done some initial benefits evaluation activities that we started last year where we've been confirming the key indicators. We will be implementing the formal benefits evaluation program beginning in the new year with our sites, where we'll begin measurement. And now we'll pass it over to Chad Lever to talk more about benefits evaluation.
Okay, hello everyone. So thank you very much, and I'm going to probably do a really fast rewind and fast forward because we've now gone through the whole framework, and monitoring and evaluation is very much a part of each and every component of the change management framework. It takes place throughout the project lifestyle, provides an opportunity to assess risks, identify issues, and develop mitigation plans. And it feeds the benefits evaluation itself when you're measuring the effectiveness of project, because initial indicators will be supporting larger benefit outcomes, net benefits that you may have identified at early phases of the project. And overall, the framework encompasses benefits realization of looking forward to the realized benefits and how they are impacting patients, clinicians, and the system as a whole. So as I said, when you start an initiative, so I'm going back to the beginning now, when it kicks off, the value proposition, the why has benefits. Why are you doing this project? When you start communicating the purpose of it, often you are drawing on the benefits that will be attained at the outcome of the implementation and the ongoing management of the implementation. And there's great ways to learn from leading practices across Canada. There have been digital health advancements and implementations in recent years with well-documented evidence. You can learn from those practices. And Canada Health Infoway has a number of resources on our reports website. And even in the United States, a growing body of literature is emerging from the value that practices have achieved from implementations. And you can also learn from other practices who have emulated what leading practices have done in their own unique way, specific to their organization or clinical setting. And of course, knowing your own setting is the best place to go and start drawing up monitoring metrics or evaluation metrics through colleague and stakeholder consultations. And I say revisited because you're always going back to them as the project develops, as you go through limited production release. You're learning what those benefits are for those particular groups. And through advanced stakeholder analysis, whereby you're really identifying not just stakeholders, but stake keepers who happen to be leaders in the organization, and also stake saboteurs who, they may have actually the gem of a pain point that a benefit that could be measured and communicated broadly across the organization that really shines the light on the why. And you want to manage those stakeholders through informing them and communicating progress in the implementation as well as achievement of benefits. So you're at the beginning, you're warming up, and the future is ahead, and you need some concrete information and evidence to show why you're going there. Next slide. This next slide is a modification of a Gartner benefits realization framework, and it's just summarized here that ongoing benefits identification does lead to realization. You keep a two-way communication with leadership and agents for change who may be clinical users or clinical champions, and you speak to them in metrics and stories that they understand and accept, and it can catapult you in the organization with respect to buy-in and governance and leadership by contributing to organizational performance management. So there may be great monitoring metrics or benefits evaluation metrics that the organization is looking at that really align with the implementation of the solution. And also it's an opportunity for you to identify a metric that the solution can offer that contributes to organizational performance management. And finally, using standards such as patient flow metrics or novel metrics such as new metrics that emerge because of the solution. So for connecting GTA, there might be a new metric with emergency room information. Great opportunity to highlight the value of the solution. It's a new metric, and the organization will really pay attention. Okay. So the next part of my presentation will touch on a benefits evaluation from London Health Sciences, a HUGO project. The purpose of their benefits evaluation, and it aligns with Infoway's benefits evaluation framework, is to demonstrate value, advance investments, encourage adoption, and highlight the necessary adjustments. So the next slide this is the Hugo Benefits Evaluation Indicator Framework. The top part is the patient safety and quality of care. That's their net benefits. And the lower half, I'll focus on the 3 orange highlighted boxes from user experience and system environment to show that they've selected some indicators that really are about monitoring, that they can use in communicating, that are part of workflow, and absolutely contribute to training and education. Next slide. So this is CPOE Utilization Report Summary, and as you can see, I apologize that it's a little fuzzy, but on the right-hand side are all the hospitals that are implementing the CPOE solution within the Hugo project. You see at the left, at the beginning, it's utilization of the actual tool, and while this particular graph just illustrates which hospitals there may be targeted efforts for change and information and more training to not say what those need to be, but where you need to focus some new efforts. In this next slide, this metric is about clicks and time per order. And the green bar at the bottom of the graph there is from the vendor. It's the vendor's average time that it takes to kind of complete the order. And as you'll see, the blue bar slowly merge and go down towards the green bar, supporting that the team is doing training and education and workflow analysis to help the clinicians use the system more effectively and aim towards the average time to complete a particular order. And this slide is help desk call volume, and I like to show this slide from the project because it is a standard metric for the organization. You'll see from the green bar there, which is the go live point, that call volume didn't spike after they went live, which is really a good news story and a testament to their efforts in training, communication, education, training, monitoring, and the workflow analysis they did, that they're really staying the same with help desk call volume, and that's a really good news story. And demonstrating improvement with these monitoring metrics does inspire net benefits. So as you look towards the solution, being used more effectively, net benefits do show up. And I just want to show a couple of benefits that came out of the Hugo project. And this slide shows MedRec and percentages of hospitals where it's improved. And as they monitored this, there were some that didn't improve, and that gave them the opportunity to specify specific change plans with those sites to move them up and help them along. And finally, a big story out of the evaluation was that medication errors were reduced, avoidance of 30 errors a month. And while this is by hospital, every hospital is different. The clinics are very different. They may have different complexities of patients they're seeing. It's not about how each hospital is doing. It's more overarchingly about how the organization is doing on a metric that may not have been measured very transparently before, and it is now.
Great. Well, thank you so much, Chad. That was great. And Melissa and Anne, great discussion. Letting you know, all of our listeners, that we are now taking questions. So if you have a question for any of our presenters, please do put them in the Q&A panel, and we will get that in and we can discuss it. But as Chad mentioned, this is the wrap-up of our 2-part Change Management Webinar Framework webinar series, and tied it together beautifully about the importance of monitoring and evaluation. And we've heard it throughout all of the presentations over the last 2 sessions about the importance of checking to see that your efforts are being efficient and being effective, and tweaking as you need, and really having them support the initiatives that you're working on. We're waiting for questions to come in. I have a few. My first one is for Anne. My question is, what is the impact on a change initiative when workflow has not been addressed? Because quite often that gets left off of change. And tell us what you've seen.
Well, thanks, Ken. The easy answer is that if it's not addressed, often the electronic or digital solution doesn't reflect the workflow that actually does occur. So it isn't efficient, and it doesn't have the clinical requirements built into it. I mean, that's sort of the simple answer. It might. That would be more luck than design, but most often it just doesn't include it. So the impact is that the users, or the clinicians, if they have a choice, they don't use it. If it is a system that they have to use, they certainly don't use it willingly. They do make workarounds, so they almost create a hybrid system because they're trying to make up for what they don't find in the electronic system, and then they're adding or supplementing it with some paper-based or other mechanisms, which definitely impacts patient safety, because then you don't have it in a one system where people are aware of all the components that are happening in that patient's or that client's flow of care. And then, of course, the other thing is that it doesn't maximize what the solution can be doing, because, you know, it might not be meeting their needs in the exact way that they had thought, but it probably has capabilities that they're not aware of. But if the workflow hasn't been done, and also if they just don't feel that they were engaged, you know, often they're not then interested in looking at how it's going to be able to meet their needs in the future, or they can work within it, because they're sort of disillusioned that their needs weren't met.
Thanks, Anne. Have you ever had the experience when workflow wasn't addressed, when they ran into those challenges, they had to go back and address workflow?
Oh, yeah, absolutely. And actually, there's sometimes those are actually even better scenarios in some ways. They're just much more time-consuming to get there, because people have now seen what it's like when it doesn't work well, so they're willing to go back and invest the time and the energy to do the pieces that they need to do, and particularly the engagement of the clinicians, looking at all the different players that are involved in that workflow. As I mentioned, not just one user or one group, but it isn't as efficient for sure, and it is more time-consuming, and often can be more costly too, not just on the human side, but also on the technology side, because you actually would have to pay for customization or upgrades that were not part of the initial contract.
Great. Thank you very much for that insight. We have a question from one of our webinar participants. The question is, we are currently in the process of implementing an EHR and are finding the physicians are the most difficult to get engaged in the process. Any thoughts or experience on improving physician engagement in the change process? I'm going to ask Melissa and Diana to give us some feedback on that.
It's Diana here. I think this is something that is relatively common. Physicians are actually busy people, and they really don't want to make time in some cases to participate. I think in our structure, we actually started with a top-down structure in terms of the program overall. So we do have an engaged executive sponsor group, and from that group, we were able to get commitment from their organization's participation. And then we have clinician champions. Now, the clinician champions that we selected, we created a role description for that group, and we started with the fact that we needed to have clinicians that were decision makers within their own organizations. So we asked for chief medical information officers to be part of the program, and actually to act as clinician champions. They needed to be decision makers because the change that the program that Connecting GTA was bringing to the organization and to the region as a whole, was one that the benefits are far-reaching and are from within the organization, across the organization. So it wasn't that we identified, you know, chief of staff from one area or a family physician from here. We actually needed those that were decision makers within the organization who could actually impact and influence the change as well. And we included them in the design process. So we made sure that they understood that we knew that they needed to be part of the requirements in the design process, and that they were part of the whole understanding what the benefits were. So when they saw what the benefits of the solution could do, we had them on board. And then within their own organization, they started to identify all of the other users. So the group that we currently have for the limited production release, our 75 users, were actually handpicked by the clinician champions to participate. And they come from across the organization as a whole. So not just physicians, but also nurse practitioners, nurses, and allied health workers as well.
Thanks, Diana. It sounds like some of the keys to your success is identifying who you need to be able to be on board to be change agents who have credibility and have some formal power and authority to influence their peers. and that seems to be very helpful.
Yeah, and from the beginning as well. We needed them right at the beginning.
Okay, now Chad has some experiences to share with us.
Yes, so I'm thinking about this question, and what occurs to me is my point around novel metrics. And when it comes to physicians, if you're working in a research-based hospital or a teaching hospital, there's opportunities, as the solution is live and is being used, that the data can be used for specific clinicians' research interests. And for example, those interested in clinical studies, they can draw from the data from the system, and will have a higher completion rate of, fields. So, no missing data, great robust studies. So there's great opportunities there. If you're not in a research environment, there's great opportunities to optimize the solution through identifying patients for proactive care opportunities. So you may have clinicians with a specific interest in diabetes or some other clinical domain, and they can proactively identify patients through the system and establish clinics and advance their care that way.
So thanks, Chad. So you're saying that by identifying novel metrics will be another way to draw in, engage clinicians to be part of champions for the program. Again, you did a great job of explaining how benefits are done, and Infoway has really, I think, championed across the country the importance of benefits evaluation and realization, building it into our investments. I'm going to ask Melissa and Diana now to talk a little bit about their benefits evaluation process, because they were just doing that. They mentioned it at the end of their presentation, to hear from the field what it's like to have to do this kind of process and how effective and helpful it's been to them.
Sure, thanks, Karen. So we're pretty early on in the stages of our benefits evaluation framework, but we have engaged, we really actually reached out across jurisdictions across the province, across the country, and have aligned with both eHealth Ontario and Infoway in terms of benefits evaluation. We're still very early on, but we actually had questions coming from both CIOs and the clinician audience right away when they engaged in the program, asking how we're going to be going about doing this and actually offering to participate in the process. So we've had a very positive experience in, I think it's a shift actually in what I've seen in the environment, because that was the first thing they wanted to volunteer for, was benefits evaluation, and we weren't quite ready yet to speak to some of that because we didn't have a product. But so we've been working very closely with them. A number of our stakeholder groups have been involved, so we've involved executives from a CIO perspective as well as administrative leadership. Physicians have been one group, and then we'll be looking at health informatics as well in whatever organizations actually have those resources. We're probably starting baseline metrics coming up in the new year, and we'll be measuring ongoing throughout. But we have a lot of different metrics that we'll be working through. I take Chad's point about having novel metrics. We've had a lot of questions around how to use the data. I think that's a bit of a challenge for our program. I think there's a lot of interest in it, but in terms of who can access the data and how it can be used, we're kind of working through a little bit right now. It's formally for clinical use. How do we move beyond secondary use to secondary use and research? And there's definitely a lot of interest in that area.
Great, thank you. We have another question from one of our participants. Can you comment on strategies you have used or are planning to use to engage clinicians in CHCs and primary care, those outside of hospitals where the existing training and engagement channels may not be as well established with regional PMOs? Great question.
It's Diana here. Yes, it is an excellent question, and we're actually in the midst of this right now because it is part of our Wave 2 activities. As part of Wave 2 planning, we did additional readiness assessments with a number of organizations. And what's different from our early adopter group for our Wave 2 group is that we are looking at more community-based organizations, CHCs, CCCs, primary care, etc. We recognize that they don't have the processes available, so what we've been looking at within our internal team is structuring our group primarily on a sector-based approach to help address and identify the needs of those specific sectors so that we can make sure that we are going to be able to provide the support that they need. So we know that with our acute sites, we have established training resources and training processes. We are going to be taking that on and develop almost a self-serve model in terms of materials, so that we understand what they need and we provide the materials that they will need to train their clinicians. We are asking for the same type of resources within the community groups in our sectors in terms of identifying a clinician champion. So it might be an office of the 3 or 4 people, but we still want them to identify someone who's going to be a clinician champion, someone who's going to be a trainer for their own staff, and we'll be delivering training direct to those groups as well, and making sure that they get the training resources that they need. So it is a great question, and we're in the midst of that development and planning right now. So,
thank you. In our discussion with CGTA, Melissa and Diana, they talked about the tools, the supports, their strategy, which is great, and it's a very large project. As we know, the numbers are quite large. Could you share with us how large your group is? Like, you're creating lots of materials. Is it a 2-woman show? Is it a 10-woman show or a 10-man show? How large is your group that actually coordinates and runs the change initiative for CGTA at a central level?
Yeah, that's a great question, Karen, and I think we're more fortunate than most. And I oversee an integrated team of, there's one dedicated communications resource who works on working with the sites. There is Diana here, who's the lead on adoption and training, and we have an additional person who focuses on development of training materials. The other person I would add is that we have a full-time clinical advisor on our program, nursing background, and so really that's kind of largely the team, and then there's administrative support that we get from other groups. But we've been very lucky in getting the right complement, and we've been lucky that we can have a team. I know a lot of shops are kind of one person's half-time job kind of thing, and we have a lot of materials. We're reaching a lot of people, so it does take resources to do that.
Yeah, thank you. That's another key point about change management. It doesn't happen on its own, and as you've seen over the last 2 webinars, there's 6 key areas, and there's lots of work to be done in each, and some of that can be specialized, like workflow, creating communication and training materials. So it really does require some expertise, and what I'm seeing across the country is people are developing change groups and change teams that have all these different skill sets in it to be more supportive of their strategies. We're almost at the top of our end of our session today, but I wanted to remind you about our available change management resources. We have a toolkit, and we have an online toolkit repository. As we mentioned, we have our Pan-Canadian Change Management Network. We have working groups that creates new products and outputs on a regular basis. We're in the process of updating our community site, so I encourage you to go have a look. In the next few weeks, you'll see a lot of new work products and tools that you hopefully will enjoy. Also, we do have our LinkedIn site where we have discussions. So please, if you have thoughts about change, things you hear about or things you see, questions you have, we encourage you to join our group and post them. So thank you again for the presenters for coming out and speaking, especially Melissa and Diana for being here twice. We really appreciate CGTA and their experience and their tools that will be available on our website shortly. Thank you for the attendees. And just to remind everyone that an evaluation will follow within a week that will include links to the PDF presentation and recorded video. Thank you very much and have a good day.